protection kits, and the aisle row and the window seat, well, they can wear just masks and face shields. So I guess travel is going to be really different. Should we have to really do that? I think even on international,
they're not going to serve any food.
Yeah, packed food. I was told that there is packed food actually.
Gagan, but the farmers have traveled very well from Punjab and Haryana to Delhi.
That is because they are motivated by the, there is political and financial motivation for them. So
okay, I think we should start now.
Yeah, from politics to neurology.
Academics, yeah.
Right.
Gagan, should I start?
Yes, please. Yes, please. Yes, Dr. Mishram, please.
Yeah, thank you. Dear friends, good morning, good afternoon, good evening, buenos dias, bonjour. On behalf of Tropical and Geographical Neurology, Specialty Group of World Federation of Neurology, Indian Academy of Neurology, and Forum for Indian Neurology Education, I welcome you all for this 7th session of WFN Neuro-Infection Series 2. The theme for today is Neurology of HIV. This session is co-organized by Pan-Africa, Pan-Arab region, and I welcome Dr. Agustina, who is the moderator for this session and the speaker too. And I also welcome the speaker, Dr. Omolara Ojo. To chair this session, we have Dr. Kigocha Okengo. She is a neurophysician and head of neurology unit at Muhimbili National Hospital in Tanzania. And she is part of African Steering Committee of the International Parkinson and Movement Disorder Society. Welcome, Dr. Kigocho.
Thank you, Dr. Mishram, for the presentation. So today we'll have...
I will, few seconds. Soon we'll be joined by the invited panelist, Dr. Diana Saylor. She is a neuro-infectious disease specialist with a focus on neurological complication of HIV. She is assistant professor of neurology at Johns Hopkins University School of Medicine. And she is currently based full-time in Zambia, where she is director of the first and the only postgraduate neurology training program in Zambia at the University of Zambia School of Medicine. And she is director of the inpatient neurology service in Zambia. We'll also be joined by Dr. Lara Benjamin, who is an invited panelist today because of her interest in HIV and stroke. And she's an honorary research fellow and consultant stroke neurologist at the Stroke Research Center, University College London, and National Hospital for Neurology and Neurosurgery. She's Wellcome Trust PhD Fellow on HIV infection and stroke in Malawi, University of Liverpool. And her current area of research is viral infections with a focus on HIV and stroke, including epidemiology, pathophysiology, and health system implementation. I would also like to welcome today's case presenters, Dr. Isabella from Ghana, Dr. Foma Kautu from Zambia, Dr. Melody Asukile, and Dr. Lauren Shimba from Zambia. And I would also have a great pleasure in welcoming the invited panelists, Professor Raj Shakir, Professor Katrak, Professor Hadi Manji, Professor Steve Lewis, and we'll be joined soon by Professor Wolfgang Rissold and others. Thank you very much. And I welcome all the audience, and we are going to have a great session. Now, I hand over to Dr. Kigocho to conduct further proceedings. Dr. Kigocha.
Thank you, Dr. Meshram. So we'll have 2 guest speaker lectures and then question and answer and then 3 case presentation. I welcome Dr. Agustina Charway-Feli. Now, Dr. Agustina Charway-Feli is a neurologist practicing in Accra, Ghana. She did her medical and neurological training in Moscow. She's a general neurologist with the practice in geriatric neurology, cognitive and behavioral sciences. She's a president-elect of the African Academy of Neurology.
It has a breast section. Oh, it has a bit of something.
She's also the vice president of the Ghana Neuroscience Society. She's the second vice president of the Ghana Epilepsy Society. And she's a member of the MDS Education Committee, EAN African Task Force, WFN Membership Committee, and WFN Tropical and Geographical Neurology Specialist Interest Group. The floor is yours, Dr. Charway-Feli.
Thank you very much. It is a pleasure, an honor, and slightly frightening to take the chair today. So far, these sessions have been top-notch, amazing.
I'm not a good person.
I'm really sorry. Can I please ask that all mics are muted? So the topic at hand today. The topic at hand today is HIV and the nervous system. I will speak about HIV itself and what it does to the nervous system, and Dr. Ojo, after me, will be talking about the opportunistic infections that HIV causes. So I will not dwell much on the physiology of the HIV virus itself.
Right.
Out here in sub-Saharan Africa, we find that because there are so few neurologists and there's such little attention to the nervous system in general by primary healthcare practitioners, that it sometimes is important to simply state and increase awareness of the fact that HIV is more than just toxoplasmosis, it's more than just TB, it's more than just wasting, etc. So that we know that there are other things that happen to an individual with HIV that require the same amount of care, and there are things that can be done to improve the quality of life of people living with HIV. So my slides are not moving.
You can click on the screen.
Click on the screen.
And then you can move ahead.
Okay. All right. So really briefly, there are 2 types of HIV virus, HIV-1 and HIV-2. These are genetically distinct types of the HIV virus. The pathogenesis and the mechanisms of affectation of both the HIV-1 and HIV-2 are comparable. The HIV-1 is the most common type, and over 90% of people living with HIV have HIV-1 as their main virus. HIV-2 is found predominantly in West Africa, but as with absolutely everything in the world right now, because of ease of transport, movement around the world, it is slowly starting to appear in other regions, including the United States, Europe, and in India. It does appear that the HIV-2 virus seems to be less virulent and less transmissible than HIV-1, and perhaps HIV-2 may be more neurotropic than HIV-1. Nonetheless, they do present in very similar fashions. So we all know that the HIV virus has a predilection for the nervous system. How does it get into the nervous system? Monocyte-derived macrophages are one of the major types of cells that are affected by HIV. CD4 T lymphocytes and dendritic cells are the other 2 types of cells. The nervous system, the neurons themselves are not directly affected by the HIV virus. However, once the HIV-affected macrophages are in the nervous system, they secrete chemokines that establish a chemotaxis gradient across the blood-brain barrier, which recruits more of the monocytic cells from the peripheral compartment into the nervous system. And this influx of HIV-1 infected monocytic cells leads to an infection of other CNS resident monocytic cells, namely the perivascular macrophages and microglia, which in turn results in greater blood-brain barrier damage and accelerates the rate at which the HIV virus affects the nervous system and enters the brain. The neurons themselves, as already mentioned, do not support the HIV infection or replication, but they do express several cell surface receptors, and there are multiple of them, and this renders them sensitive to damage from the viral proteins, such as TAT and GP120, the inflammatory cytokines, and small metabolites. And these lead to the damage and eventually the pathogenesis of the disease that we see in HIV. So multiple systems, or multiple parts of the nervous system can be simultaneously or sequentially affected by the HIV virus. In the era before widespread use of antiretroviral therapy, up to 80% of patients were symptomatic of neurological disease, and currently up to 30% of patients, and higher depending on the region, have neurological symptoms as the first initial clinical problem. So we all know that, again, in sub-Saharan Africa, for a variety of reasons, healthcare seeking behaviors are less than they are elsewhere, and very often a seizure or a stroke or loss of neurological function is the reason for seeking medical attention for the first time. And we all know neurological syndromes can be the sole clinical problem and often lead to death. So the differential diagnosis of a neurological syndrome, any neurological syndrome, depends on the history, clinical findings or localization, and if we identify that HIV is implicit in the condition, the HIV disease stage. So are we at the stage of seroconversion? Is this early disease, or is this late disease and AIDS defining conditions? The causes for neurological disease and HIV infection, as already mentioned, can be the HIV virus itself. So the result of the presence of the HIV virus within the nervous system. And this can be acute or chronic. Secondary opportunistic infections can also add to neurological disease or be the neurological disease, as well as malignancies that affect the nervous system. So as well as the disease itself, metabolic or nutritional derangements that come from chronic illness can also lead to neurological disease or complicate pre-existing neurological disease. And then we have the complications of medical therapy as well to take into consideration. So the neurological manifestations directly attributed to the HIV virus, the HI virus itself, are acute viral meningitis. You can have a chronic meningitic syndrome, dementia associated with the virus, vacuolar myelopathy, peripheral neuropathies of multiple kinds. And there is a direct relationship between the neurological complications, the phase of the HIV infection, and the level of immunological involvement. Moreover, it can occur simultaneously on multiple levels of the neuraxis. So like some of the diseases that we have mentioned here before, it can affect any part from the cortex down to the neuromuscular junction and can facilitate the coexistence of multiple complications. So as already mentioned, some of the primary or HIV-related syndromes of acute infection, so that's when the individual first becomes exposed to the virus. You can have meningitis or encephalitis, seizures, which can be generalized or focal. Transverse myelitis is a syndrome that can occur, as well as cranial neuropathies, usually Bell's palsy, or an acute inflammatory demyelinating polyneuropathy, GBS type neuropathy. Sometimes you do have polymyositis as the first indication of disease. So with common disorders, you do have meningeal pleocytosis, and that can be symptomatic or asymptomatic. You may have dementia or psychiatric disturbances, and this is usually in late-stage disease, stroke, seizures, progressive myelopathy, and the neuropathies. Now, to one of the first early signs of HIV infection is acute aseptic meningitis. And up to 50% of individuals in acute infection may have elements of acute aseptic meningitis, which can be differently clinically prevalent. So from mild disease that doesn't make the individual seek medical attention, and even when they do, sometimes in our tropical setting, the first diagnosis that is made easily at primary healthcare level is a misdiagnosis of malaria or another febrile illness like typhoid fever, etc., rather than the HIV itself. If the individual's meningitis is pronounced enough that they get a lumbar puncture, usually we see lymphocytic pleocytosis in the CSF. With a detailed history, one can often elicit a 2 to 6 week history of a flu-like illness that precedes the meningitic syndrome. So this usually occurs in acute infection or during seroconversion, or can sometimes be part of the chronic stage of infection. It is clinically indistinguishable from any other kind of viral meningitis. And the symptoms, as in most meningitis, is fever, malaise, stiff neck, photophobia occasionally. And in late infection, the meningitis can be caused not just by the HIV virus itself, but usually then together with or solely by an opportunistic infection or a malignancy. Again, when we do our CSF analysis, as opposed to other forms of aseptic meningitis, we do see a lymphocytic pleocytosis, normal glucose levels, and normal to slightly elevated protein. So if you have someone who's ill and your CSF is not helpful, think HIV. The HIV, however, serology may be negative, and so requires repeating at 3 and 6 months. If you look for the antigen, however, those are usually positive if HIV is the culprit in the meningitic syndrome. T-cell studies are usually normal or borderline, and EEG, CT scan, MRIs of the brain are usually normal or non-diagnostic, not helpful in determining the cause or the character of the disease. The outcome is usually good with little or no sequelae. It tends to be self-limiting, so whether we treated it or we didn't treat it, the individual tends to improve. Sometimes there's residual cranial neuropathy. It can be a singular or multiple, and sometimes the meningitic syndrome can lead to a facial nerve palsy. After recovery, usually the individual goes back to a normal, healthy state of being, and they remain in that latent period for quite a while. So in our setting, when we see someone with Bell's palsy, so no other neurological deficit aside from a peripheral facial nerve palsy, be it unilateral or bilateral, we need to rule out HIV as a cause. So as mentioned, it can be unilateral or bilateral. It is usually a syndrome of seroconversion in early infection. Again, if CSF analysis is done, it shows lymphocytic pleocytosis, which shouldn't be the case in a benign, in inverted commas, Bell's palsy. Again, because this is early in the illness, the HIV serology can be negative. And the outcome is about the same as non-HIV Bell's palsy, with recovery being the rule. So in terms of affectation of the peripheral nervous system, you can also have an acute inflammatory demyelinating polyneuropathy, or a GBS-like syndrome with ascending limb weakness, no different than the GBS that we all know, with sensory loss and areflexia. And the only difference between GBS that is non-HIV and GBS that is HIV related is the presence of lymphocytic pleocytosis. So in normal in inverted commas GBS, aside from the cell protein dissociation, the cell count should be practically normal. And in HIV, you have a slight elevation with the pleocytosis. And as in non-HIV GBS, the recovery is solely dependent on the severity of the syndrome itself. So the more pronounced the neurological deficit at the beginning of the illness, that will require longer time for recovery, and there may be residual deficit. Just like ordinary Guillain-Barré syndrome, it responds to plasmapheresis or intravenous immune globulin if that is available to you. So for most of us, again, in sub-Saharan Africa, neither plasmapheresis nor IVIG is available, but in some settings it can be. So if you do have it available, please by all means use it. So your first neurological syndrome can also be a transverse myelitis, and just like any other transverse myelitis, it presents with limb weakness, sensory loss, bowel and bladder dysfunction. It's usually located in the thorax, and one of the presentations, as represented here, it can have a longitudinally extensive character to it, leading to having to differentiate it with things like neuromyelitis optica, other infections, other inflammatory conditions. It may respond to plasmapheresis, steroids, or IVIG. For us, mostly it would be steroids that are available. And the outcome is again dependent on the severity of the neurological deficit that is caused. However, since the introduction of highly active antiretroviral therapy, this kind of transverse myelitis is seen relatively rarely, and less than 10% of HIV patients will develop transverse myelitis. You can have a picture of polymyositis, and the main complaints here are muscle pain and proximal weakness. You may or may not have myoglobinuria. As with other forms of polymyositis, you will have elevated creatine kinase levels and see myopathic changes on electromyography. Usually this is self-limiting and may be steroid responsive. It occurs rarely. So this is not common at all. It occurs rarely during seroconversion or in early HIV. So the primary syndromes that we can attribute to the HIV virus itself in chronic infection are the neurocognitive disorders that we see in HIV. Severe manifestations, we will have HIV-associated dementia complex, and that's when the cognitive impairment is severe enough to warrant the diagnosis of dementia. It is sometimes associated with and occurs concurrently with myelopathy. In mild manifestations, and that's what we see more often now, again, since the era of antiretroviral therapies, HIV-associated minor cognitive and motor disorder. So the cognitive impairment here is usually not enough to warrant disruptions in activities of daily living, but are identifiable on neuropsychological testing. The features of acquired immune deficiency syndrome dementia is usually in the form of one doing neuropsychological testing, executive and frontal subcortical dysfunction. There is some memory impairment, but the predominant feature is the executive dysfunction. You can also have associated psychiatric symptoms such as anxiety, psychosis, mania, depression, and again, as mentioned already, may coexist with myelopathy or peripheral neuropathy. The laboratory findings, the risk increases of developing dementia increases with disease severity, and it's more common when you already have age-defining and acquired immune deficiency. And that's usually at the level of the CD4 count being less than 200. Your cerebrospinal fluid on analysis can be normal, or there's a non-specific pleocytosis with normal glucose and protein. And CSF gamma globulin is often elevated. When we do neuroimaging, aside from non-specific cortical atrophy, subcortical atrophy in the form of ventricular dilatation, white matter rarefaction on CT scan, flare hyperintensities on MRI. There are no specific changes that are attributable directly to the HIV that can be discerned from the imaging. So when you have an individual who's HIV positive and has a dementing syndrome, you need to rule out other causes for the dementia as well. And finding no other cause, then the settling diagnosis is HIV-associated dementia. So as I mentioned, you have to have a list of differential diagnoses. You need to rule out toxic and metabolic factors, the use of medications, electrolyte imbalance, B12 deficiency, other nutritional deficiencies, and nutritional toxins. You need to rule out the cognitive impairment being a result of secondary opportunistic infection or a secondary malignancy, or unrelated to the HIV entirely, progressive neurodegenerative disease. To be able to differentiate, you need to stage the infection using the CD4 count and the viral load. By all means, like with any individual with cognitive impairment, a full blood count, kidney and liver function, syphilis, serology, B12 levels, thyroid function, arterial blood gas were indicated. A CSF analysis is often required as well, unless the previous investigations have already given a solid answer to the questions. Blood needs to be cultured for Methylbacterium avium, cytomegalovirus, different fungi. And of course, like with any other condition, you need to do imaging of the brain. MRI is the imaging of choice with the use of contrast, unless the contrast is contraindicated by either renal impairment or some other condition. So with the use of antiretroviral therapy that is now widespread, we appear to see less of dementia in HIV positive patients. However, when we do have a cognitive impairment, there are no specific therapies that have been approved for HIV dementia in particular. So we do use what we would use for other diseases such as Alzheimer's disease, but the efficacy has not been proven, and you have to manage your patients as is locally acceptable. So whatever practice you have in your region for managing cognitive impairment. It also depends on the severity of the cognitive impairment and the pill burden the individual is already on, so that you don't add unnecessarily to the pill burden for something that may or may not have an effect on the cognitive impairment. So here I would pause really briefly and give you a short case about how sometimes it is difficult to tell the difference between all the different possibilities for the cognitive impairment. So I had a 65-year-old male patient, IO. He was well educated. He was a professor in a teaching university. He had been known to be HIV positive on antiretroviral therapy for the last 3 years, and he was compliant. He was also diabetic and hypertensive, so we have confounding factors here. However, so I saw him for the first time with a history of 2 months of inappropriate behavior. He had started walking around naked. He had become argumentative with people at home. At this time, he had already been retired from teaching, so he spent most of his time at home. There was his family that noticed the difference. And in fact, they had a few difficulties chasing him around the house and out on the street when he would just walk around bare. On his neurological exam, there was no focal neurological deficit, not counting the cognitive impairment, aside from global areflexia, and we were unable to do a thorough sensory examination because of the extent of his cognitive impairment. He was not answering appropriately to the question, so we couldn't tell whether or not there was any mild. So there was no severe, definitely, but we couldn't tell if there was any mild sensory impairment. So during neuropsychological evaluation, we used a screening test and then a mental state examination, and he scored 23 out of 30, mostly losing points for poor orientation in time and impaired count, he actually did pretty well with memory. And it is also one of the reasons why the mini mental state examination, because it was designed with Alzheimer's disease in mind, it's very memory based and verbal based. It can often miss executive dysfunction. And when we did the frontal assessment battery, he scored 11 out of 18. There were other tests that were done which showed a predominant frontal subcortical dysfunction. CSF analysis was done, and it included testing for syphilis, Indian ink staining for cryptococcus, PCR for TB was also done, herpes virus serology was also tested for, and none of that gave any yield. The parameters of the cells, the protein, the glucose were all within normal levels. So for this gentleman, because he was diabetic, he was hypertensive, his MRI also showed no significant lesion to which we could attribute the cognitive impairments to. So he had cortical atrophy. So he had some cortical atrophy, ventricular widening, but nothing significant. He had very little periventricular white matter changes. He had small nondescript white matter changes in the subcortex, but again, nothing that we could say, now that's the reason for the cognitive impairment. So for him, we came to the conclusion that it was probably HIV-associated cognitive impairment, confounded by his pre-existing hypertension and diabetes, even though those were also under control. Over time, and I've been seeing him for the last 7 or so years, he has progressively become quieter. The executive dysfunction is greater. Now he is less voluble, he argues less, he comes into clinic, he's very quiet. Sometimes he recognizes some of his old students and chats pleasantly with them, that they don't even recognize that he has a cognitive impairment. But he has deteriorated. We tried using memantine hydrochloride. We got to maximum dose, but to be honest, there was no significant change or any discernible change in his cognitive impairment. And lately, because again of the pill burden, fatigue from the part of his relatives in acquiring his medications, we have abandoned the use of memantine. And it hasn't reflected in any way in the state of his cognition. So cognitive impairment aside, the other problems that we face are progressive myelopathy, especially as disease progresses. Clinically, this presents with progressive spastic leg weakness. There can be erectile dysfunction, sphincter dysfunction, and it usually coincides with cognitive impairment and peripheral neuropathy. The diagnosis, like with cognitive impairment, is based on the exclusion of other causes. So like with any myelopathy, your investigation should include an MRI of the level at which you find the myelopathy, B12 levels, serum B12 levels, CSF analysis to rule out infections such as syphilis, rule out other inflammatory causes, other reasons for demyelination, such as neuromyelitis optica. Unfortunately, there are no proven therapies again, except when specific treatable conditions are the reason for the myelopathy that are not directly related to the HIV. Late stage, chronic stage of infection, we have myopathies, and these can be made worse or caused by medications, the HIV virus itself, and sometimes secondary infection. And like any myopathy, it presents with progressive proximal limb weakness. Investigations, as in all myopathies, will show creatine kinase elevations, myopathic features on electromyography, and the definitive diagnosis is made by muscle biopsy. If an offending medication is identified, that medication needs to be stopped. Sometimes a trial of steroids and plasmapheresis may make a difference. And if there is a secondary infection, that by all means needs to be treated. So the kinds of peripheral neuropathies that occur in chronic HIV infection are multiple. We have distal symmetrical polyneuropathy, inflammatory, demyelinating polyneuropathy, chronic type, mononeuritis multiplex, isolated mononeuropathies, progressive polyradiculopathy, and autonomic neuropathy. Now, again, like with all conditions, you need to rule out an offending toxin, a nutritional deficiency, etc. Now, I'm sure my colleagues will back me up when I say that, unfortunately, our diagnoses of these conditions is usually very, very low. And the reason being that when we have someone with HIV, most of the time we're dealing with late stage HIV where the predominant problem is the opportunistic infection, severe brain disease, severe lung disease, and often the complaints of the individual are just simply not taken into consideration. So we say the person has toxoplasmosis and we treat that, and we pay very little attention to anything else. But now that we have more people on antiretroviral therapy, perhaps we should pay more attention to these complaints and address them, because the whole goal of any kind of therapy is improving quality of life, and quality of life does not go up if you are constantly in pain or have a dysfunction that disrupts your activities of daily living. So as with all the other forms of neuropathy, you need to rule out another cause for it. The most common neuropathy of HIV is the distal symmetrical polyneuropathy, and differential diagnosis is HIV related, drug or treatment related, associated metabolic or nutritional disorder, and that's for our severely ill patients who are not eating properly, whether it's the reason it's caused by a secondary infection, and often totally unrelated to the HIV illness itself. Like with any polyneuropathy, clinically, we have painful paresthesias of the feet and soles, shooting pain legs, numbness, weakness, which is either subjective or very mild, and on sensory examination, a stocking glove pattern of sensory loss, decreased vibratory sense, position sense may be normal, and usually with absent or reduced deep tendon reflexes, most prominently in the Achilles reflexes. So the etiology, again, directly related to the HIV, it can be from cytomegalovirus, the hepatitis virus, Mycobacterium avium, and other infections. Nutritional, we'll keep repeating this. It may be autoimmune, and there are a multitude of autoimmune antibodies that we can look for. And we always have to take into consideration that it may be related to the medications that the individual is taking. Again, like with any polyneuropathy, first look at the drug list and then move on. So autonomic neuropathy can cause orthostatic hypotension, impotence, diarrhea, and the etiology is presumed to be HIV-related sympathetic gangliononeuropathy. It's important as a potential cause for sudden cardiac arrest during procedures, so it needs to be borne in mind. Evaluation is the same as already mentioned. The neuropathy treatment also, plasmapheresis, immune globulin is the preferred form of treatment, which is often not available. Pain management, like all other neuropathies, we use anticonvulsants, tricyclic antidepressants, and opioids. However, if the individual is on antiretroviral therapy, which they usually are, please take into consideration drug interactions. Carbamazepine, phenytoin, not the best drugs in terms of drug-drug interactions. Amitriptyline definitely also. However, you need to make a choice in terms of either helping the person or temporarily choosing a drug that will provide relief and then go back to their medications. So in conclusion, I want to talk very briefly about the aging population and HIV in the era of antiretroviral therapy. So now we find that patients are living much longer. Their life expectancies is approaching that of individuals without HIV. However, we still find that even though they may seem relatively healthy because they are on antiretroviral therapy, their viral loads are low, they appear to be at a higher risk than the general population of getting a stroke. We spoke about this a few sessions ago when Dr. Benjamin presented the case with stroke and HIV. They are also directly related to the HIV, more prone to developing cognitive impairment to the extent of dementia, as well as potentiating the development of neurodegenerative diseases that present with dementia, as well as other neurodegenerative diseases. So when we're seeing our patients, we need to always ask them what their past medical history is. Always go through the drug list of the individual. There's so many clues there. We find that a lot of our patients, because of stigma, if they're doing pretty well, they won't tell you that they are on antiretroviral therapies. And if you don't ask directly, if you don't find the ways and means of going around and asking the question, you may miss an important cause of their illness. We also have this discussion when we were talking about stroke and HIV, the cases that were presented a few sessions ago. It is a bit difficult. In some of our countries, we have legislation that prohibits testing for HIV without first having counseled a patient. And whilst I agree absolutely 100%, it is vital not to do anything to or for your patient without their consent. Some of the tests that we do are done with implied consent. So for example, when someone comes to the hospital, you examine them, it is implied that they have acknowledged and consented to the examination. When you do your standard full blood count, kidney function, liver function, whilst you still need to tell the individual what you're doing and why you're doing it, I think we should be more readily talking to our patients about testing for HIV, not to say that, not to heighten the fear of HIV and to increase stigma, but to alert them that this may be the problem. Why don't we do it? If the test comes back negative, hooray, we don't have to worry about it anymore. And that's always a cause for celebration. And if it does come back positive, at least we know that we need to manage this as well. So we need to talk to our patients, make testing more readily available, counsel them so that they're not afraid of it, and know that there are ways to manage all the issues. So with that, I think I will pause and let Dr. Ojo speak about the opportunistic infection. Thank you.
Thank you, Dr. Charway Feli, for this brilliant presentation. So now we invite Dr. Molara Ojo from Nigeria to present. She's presenting on opportunistic neuroinfections in HIV.
Mansi, can you project her CV? Mansi?
Can you project the CV, please?
Sharing the screen. 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 Hello.
Can I share my screen?
Oh God.
No, it is not there.
Hello.
Mansi?
Hello, can you see my screen?
No, it just shows CPML, CMPL tech support. It doesn't show CV of Lara. Yeah, okay, now it is there.
Thank you. Dr. Omolara Ojo, she's a senior lecturer at the University of Lagos and the consultant neurologist at the Lagos University Teaching Hospital. She earned her medical degree and her neurology residency at the Ilorin Teaching Hospital in Lagos. And she has an interest in medical education, specifically in the curriculum development and implementation. Her current research focuses on movement disorders and stroke. Welcome, Dr. Lara.
Thank you very much for having me, and thank you to the organizers for inviting me. Can I share my slides? Can I share my screen?
Yes.
Yeah, you can share.
Okay. Are we good? So thank you to Dr. Shawifeli for that presentation. It has actually made my own presentation easier. And I'll be talking about the opportunistic neuroinfections in HIV that are pertinent to this seminar or webinar. And I will be following this outline, just a brief introduction, very few things to add to what Dr. Chawifeli has already discussed. I'll be taking the major opportunistic infections and then other neuroinfections that may be opportunistic. And many times we regard things like tuberculosis of the CNS as endemic. So many times people don't think about it as an opportunistic infection. However, when you are thinking about opportunistic infections in HIV, you must have that at the back of your mind. Then I'll briefly just say a few things about how to approach the evaluation of a patient living with HIV who presents with neurologic features. So as part of an introduction, opportunistic infections remain one of the neurologic complications of HIV, and Dr. Chawifeli has already spoken about the other neurologic complications. So neurologic complications can arise as a direct effect of HIV, as aberrant immune response that we all know as IRIS, and also as side effects or adverse effects of the medication. And opportunistic infections actually represent an effect of uncontrolled HIV infection. So it goes without saying that if a patient develops an opportunistic infection, that person has an underlying uncontrolled HIV infection. While over the past decade or two, the epidemiology of CNS opportunistic infections has changed drastically in high-income countries. So if you're reading about neurologic complications of HIV in publications from the US, from the UK, there's very little on opportunistic infections. And that's because of their early detection, early treatment retention, the incidence of these opportunistic infections has reduced drastically. However, the converse is the case in low and middle income countries, and especially countries in sub-Saharan Africa, where we have a very high burden of HIV. And the reasons are very simple. We have new delayed infections. So many of the new HIV infections are coming from low and middle income countries. Undiagnosed HIV status for decades, late HIV diagnosis, and even when we diagnose, there's restricted access to medications, especially heart or combination antiretroviral therapy, depending on the region you are from. And then where the patients even have access to heart or combination antiretroviral therapy, there's very poor medication adherence. Another thing we need to have at the back of our minds are that multiple opportunistic infections can occur simultaneously, and this becomes a problem with management, as we will see later on in the discussion. So I'll be looking at the big three, as I call them, in terms of opportunistic infections in HIV/AIDS: cryptococcal meningitis, cerebral toxoplasmosis, and PML, or progressive multifocal leukoencephalopathy. Before the presentation ends, I'll also say something about tuberculous meningitis. You cannot talk about CNS neuroinfections in HIV and not mention tuberculosis, especially in endemic areas. So starting off with cryptococcal meningitis, as we all know, it is caused by an encapsulated yeast known as Cryptococcus neoformans. That is the organism responsible for most of the infections. However, we must have at the back of our minds that there's also Cryptococcus gattii. And while Cryptococcus gattii is seen more in the HIV negative population, it does account for some percentage of infections in HIV positive people. Sorry about that. It remains a major cause of HIV-related morbidity and mortality in low and middle income countries, especially sub-Saharan Africa. In fact, almost 75% or 3/4 of the mortality, annual mortality due to cryptococcal meningitis is occurring in sub-Saharan Africa. And there is no riddle or puzzle as to why this is still a problem in Africa. It is identified as a marker for HIV programs treatment failure. So if you want to assess the success or the failure of an HIV program, just look at the incidence or the prevalence or the frequency of cryptococcal meningitis where that program subserves. And the reasons for this are not far-fetched. As I mentioned earlier, and as Dr. Chawifeli also mentioned, we have late diagnosis, failure of treatment retention, and then to boot, antiretroviral resistance. In terms of presentation, cryptococcal meningitis does not present usually as our typical fulminant acute bacterial meningitis. No, the presentation is a bit more subtle, a bit more insidious. Usually the patient presents with a new onset headache or a change in the pattern of headaches. And this would have been going on for weeks. If you remember, usually one of the key signs with, or key symptoms with cryptococcal meningitis is photophobia. However, that photophobia may or may not be present in the HIV positive population, especially when they are very immunosuppressed. So you do need to have this at the back of your mind. The fact that somebody has headaches and does not have a photophobia does not negate a suspicion of cryptococcal meningitis. And usually the population that would have come down with cryptococcal meningitis are very immunosuppressed. So we're talking about CD4 T cell counts less than 200, and in many cases, less than 100. So they have a chronic headache, they may have confusion, they may have a fever. When they start developing complications such as raised intracranial pressure, they develop nausea and vomiting, seizures, and may have focal weakness and complain of things like diplopia. So how do we make a diagnosis? The diagnosis relies on a good clinical suspicion. So if the patient is a known HIV patient, it makes it a bit more easy. But as I will talk about before the end of the presentation, you will realize that especially in sub-Saharan Africa, this is a bit more difficult than it seems, and especially because opportunistic infections do tend to coexist or co-present. However, once you have your clinical suspicion based on the presentation, based on the risk factors, you need cerebrospinal fluid analysis. And most of the time, our usual parameters, so looking at the cell count, looking at the protein levels, they may be normal or just mildly deranged. So they are very non-specific. So if you have a suspicion of cryptococcal meningitis and you have a markedly elevated cell count, you have marked pleocytosis or a very deranged CSF protein, please look for alternative diagnosis. So you're looking for at the opening pressure, and this does not just confirm a diagnosis of meningitis, it also has its own place in the therapy, as we will see later. Fungal culture is the cornerstone of diagnosis, but as we all know, fungal culture takes weeks, and we cannot rely on this to institute treatment. The cryptococcal antigen has become the bedside or clinical adjunct to making a diagnosis, especially in the CSF and not in the serum. And then India ink staining still retains its place, especially in places that are resource poor. So if you cannot do fungal culture, you do not have access to cryptococcal antigen, you can still send CSF samples for India ink staining to confirm your diagnosis. I have already mentioned the other CSF parameters. Now, a serum cryptococcal antigen titer, while it is not diagnostic, if the titer is greater than 1 in 160, it does support your suspicion of cryptococcal meningitis. Now, as Dr. Chawifeli also mentioned, brain imaging, neuroimaging is very important in these patients, especially when they have come in with focal signs or focal symptoms. Now, many times in sub-Saharan Africa, there's an argument or a controversy, oh, should we image the patient before doing a lumbar puncture? Yes, while lumbar puncture, neuroimaging is advised before a lumbar puncture, if the patient does not have focal signs, focal symptoms, please do not delay the lumbar puncture because of that. And as Dr. Chawifeli mentioned, the MRI is more sensitive. However, if what you have available to you is a brain CT scan, please go ahead and do this. However, it must be contrast enhanced if there are no contraindications. Now, in terms of treatment, there are two things that are the cornerstones of management. So that's antifungal therapy and management of the raised intracranial pressure that tends to go along with cases of cryptococcal meningitis. Now, in terms of antifungal treatment, recommended antimicrobial therapy. So there was a whole session on this, if I remember correctly, about last week or 2 weeks ago. And usually the recommendation is for induction with parenteral amphotericin B with oral flucytosine for 2 weeks or until the CSF is sterile, then followed by fluconazole for 8 weeks, then followed by fluconazole at a lower dose until the patient has sustained a CD4 count that is greater than 200 cells per millimeter cubed for more than 6 months. That is until the suppressive phase has been completed. However, as we all know, in resource poor settings, there are challenges with this recommendation. The challenges have to do with cost, and cost is not just a challenge for us, it's also a challenge even in high income countries. If you go back to previous discussions that have been held with this series, you will find out that a course of amphotericin B or a complete treatment runs into thousands of dollars. However, for high income countries, they have insurance, they have other policy things in place that make sure the patients get the treatment they need. We do not have that in sub-Saharan Africa. Another problem is that amphotericin B is difficult to find depending on your locality. So it's about availability, it's about cost. Now, in view of this, there was a study published in the New England Journal of Medicine, I think in 2018, and because of that, recommendations are being changed when it comes to management of cryptococcal meningitis in Africa. And what the authors of this paper set out to do was to try to see whether patients who have a reduction in the duration of the combination therapy overall and in terms of the treatment. And excuse me, what they did was to randomize patients to either an oral regimen of fluconazole plus flutisotine or 1 week of amphotericin B and then 2 weeks of amphotericin B. And what they found out was that the 1 week course of amphotericin B plus flucytosine and 2 weeks of fluconazole plus flucytosine were effective as induction therapy for cryptococcal meningitis in resource poor settings. So this is all well and good. However, as I mentioned earlier, in low and middle income countries, sometimes you can't find either the amphotericin B or the flucytosine. Depending on where you practice, if you have patients in this category, you may need to get in touch with your infectious disease specialist or people who work with the PEPFAR or APIN, who are able to provide some of these medications at a subsidized cost or even free of charge. So if you are in this scenario where you cannot lay your hands on either of those two induction agents, an alternative regimen will just have to be fluconazole at 1200 milligrams per day. Now, the second and also important part of managing cryptococcal meningitis is management of the raised intracranial pressure. And that is why you must check the opening pressure when you are evaluating a patient who has cryptococcal meningitis. If the opening pressure is more than 25 centimeters of water, some authors or authorities or recommendations will say 20 centimeters of water, then you must aim to reduce the opening pressure by at least 50%. And the way you go about doing this is to go about doing daily lumbar punctures. Sometimes that is not enough to even reduce the markedly elevated opening pressure. And if the person is at risk of herniation, you may need to put in a lumbar drain or a ventriculostomy. In the early days of HIV/AIDS, cryptococcal meningitis in HIV/AIDS, there was the issue of steroid therapy just to reduce the raised intracranial pressure. However, we now know that there is no role for steroids, specifically dexamethasone, in the treatment of the raised intracranial pressure that accompanies cryptococcal meningitis. Moving on to cerebral toxoplasmosis, it is caused by the protozoa Toxoplasma gondii, and clinical disease results from reactivation. So most of the time people have acquired this infection early on in life by coming in contact with the oocyst, either from a cat or eating contaminated protein or protein that has not been cooked or treated well. And once reactivation occurs, the clinical disease mainly affects the brain. Patients present with headaches, fever, confusion, seizures, focal neurologic deficits, and because of a tendency to affect the basal ganglia, they can also present with movement disorders or varying form of involuntary movements, ataxia, hemichorias, hemibalism. A very few of these patients may also come in with a fulminant encephalitis-like presentation. In terms of a diagnosis, you need a brain imaging in this case. And what it's going to show you are the, I think I have, yes. So patients will come in with this kind of picture on their imaging. So this is a CT showing multiple ring enhancing lesions with edema. You can count almost up to 6 or 7 lesions here. And then this is an MRI showing at least 2 lesions. So what the typical patient who has cerebral toxoplasmosis presents with multiple enhancing lesions on new diagnostic protocol. You now finding IgG antibody positivity in this kind of patients is not diagnostic. As I said earlier, infections have been acquired earlier in life. So an IgG doesn't tell you, it just confirms that this person has had contact early in life. That may still give you some support to your diagnosis. So if I have an HIV positive patient who has a presentation with focal neurologic deficit, can't have neuroimaging done, and I check the toxoplasma serology and there's IgG positivity in the face of immunosuppression, so a CD4 count less than 200, I will consider treating for toxoplasmosis until I can do that neuroimaging. IgM antibodies more readily signify a recent infection. In terms of management is divided into a primary phase, which usually takes place over 6 weeks, and a secondary prophylactic phase that is also known as a chronic suppressive therapy phase. So for the primary phase, that is done with pyrimethamine, standard recommendation, plus sulfadiazine at the doses outlined on the slide. However, in some areas, for example, in Nigeria, sulfa drugs are usually part of combination drugs, either as antibiotics or as antimalarials. We rarely get the sulfadiazine on its own. So if you fall into that category, you can consider giving pyrimethamine plus clindamycin. Also, if your patient has sulfur sensitivity, you must replace the sulfadiazine with another drug, and that is usually clindamycin. You must give your patients folinic acid supplementation throughout this therapy. For the secondary prophylactic phase, the doses just reduce as outlined on the slide until the person's CD4 count increases, and then you can, above 200, and then you can put them on secondary prophylaxis with trimethoprim, sulfamethoxazole. Now, for treatment of cerebral toxoplasmosis in resource-poor settings, so as I mentioned earlier, sometimes you cannot get sulfadiazine on its own. Sometimes you don't have pyrimethamine on its own. They have been combined into their different antibiotics or the different antimalarials. Then you can give the patient double dose. So that will be 960 times 2, 960 milligrams times 2 of trimethoprim sulfamethoxazole twice a day. And you can also consider giving atovaquone if you have access to that in people who have sulfur sensitivity. Moving on to progressive multifocal leukoencephalopathy. It's a very rare but severe CNS opportunistic infection, and is caused by reactivation of latent JC virus infection. Usually is characterized by very subacute presentation and many times progressive neurologic dysfunction that's characterized by mental status changes, a lot of cognitive issues, gait and coordination issues or difficulties, and limb weakness. One of the things that is missing here is the fever. So you won't get fever in a patient presenting with progressive multifocal leukoencephalopathy. And their course tends to be a bit more progressive and more chronic than patients that have presented with the former 2 opportunistic infections I presented. There is no specific treatment against the JC virus. So the treatment for progressive multifocal leukoencephalopathy actually is targeted at restoring the patient's immunity. So you must commence or revise the heart therapy or the combination antiretroviral therapy that patient is on. Moving on to other opportunistic neuroinfections, as I mentioned earlier, you cannot talk about neuroinfections in HIV/AIDS in areas that are endemic for HIV without talking about tuberculosis. And the funny thing, or what makes it a bit more difficult is the fact that areas like sub-Saharan Africa that have a high rate of transmission, a high rate of new infections of HIV also constitute the countries with a high prevalence of tuberculosis. More than 50% of people with HIV and TB co-infection will develop extrapulmonary TB. And for extrapulmonary tuberculosis, one of the most common sites is the CNS. Also, persons who are HIV positive are up to 5 times more likely to develop CNS involvement during TB infection than individuals who are HIV negative. And that is why you will notice that when there is a new HIV diagnosis, the person is screened for TB. Same thing, when there is a new TB diagnosis, the person is screened for HIV. It is because of the co-occurrence or co-infection between the two. HIV infection increases the risk for acquiring TB and also for progressing from latent infection to the active disease. CNS tuberculosis is not just one disease, it can be a gamut of presentations ranging from tuberculous meningitis to tuberculomas, to tuberculous abscesses, and even to spinal presentations with myeloradiculitis. For this presentation, I'll be focusing more on tuberculous meningitis. You can't have practiced in a low and middle income country and not have managed cases or patients presenting with tuberculous meningitis. And we all know the difficulties that are inherent with the diagnosis and with the treatment. The clinical features usually develop insidiously, and common symptoms include fever, usually not the high-grade fever of the acute bacterial meningitis, unless there is a superimposed infection, but it's usually more low-grade, more indolent, a lot more constitutional symptoms, lethargy, apathy, seizures, altered sensorium, and even vomiting. And examination usually will reveal cranial nerve deficit, and that is because of the penchant of the disease to affect the base of the, basal meninges and the ambient systems. In terms of a diagnosis, just like before, we need cerebrospinal fluid analysis. And here you will see a mild pleocytosis, markedly elevated protein. And many of us will remember the spider web or pellicle formation. So if you have a patient who presents with what you suspect is a TB meningitis, you do not have access to a lab nearby, you can just leave the CSF to stand for at least 6 hours. If it forms a pellicle or a spider web on top, you have marked protein levels in that CSF. And that supports your clinical suspicion of tuberculous meningitis. Elevated adenine deaminase is also being used now as a supportive feature on its own. It is not diagnostic of tuberculous meningitis. Now, microscopy with the Zell-Nelson stain is a bit more difficult with CSF analysis. Patients with tuberculous meningitis usually have a paucity of the AFB in the CSF. However, you can increase the yield from about 30% to about 80% if 3 separate samples of CSF are stained, as opposed to just staining one CSF sample and moving along. Microbacterial culture is good, diagnostic. However, we all know that takes weeks, and you do not have weeks when you are managing a patient who has tuberculous meningitis. Tuberculous PCR assays are available, a lot more available in high-income countries than in the low-income countries. One thing you must note is that for tuberculous PCR assays, negativity does not rule out a diagnosis of tuberculous meningitis. And then of recent, the last 5-10 years, cartridge-based nucleic acid amplification, so the GeneXpert nucleic acid assays are now mainstream, and they're now part of the World Health Organization recommendation for diagnosis of tuberculous meningitis. You cannot manage a patient with tuberculous meningitis without doing neuroimaging. And as I mentioned earlier, one of the features that are in keeping with TBM are basal meningeal enhancement, hydrocephalus, and you can even pick tuberculomas, remembering that tuberculomas tend to be supratentorial in an adult and infratentorial when dealing with children. Now, when you suspect that you have a patient who has presented with a tuberculous meningitis or any other form of a CNS tuberculosis, kindly start empiric treatment for presumptive CNS TB immediately while you are investigating and evaluating the patient. In terms of treatment, the World Health Organization recommendation is still the same as for pulmonary tuberculosis. So you have 2 months, which is the intensive phase of rifampicin, isoniazid, pyrazinamide, and ethambutol. That's the 4-month, 4-drug combination, followed by the continuation phase of 2 drugs for 10 months, rifampicin and isoniazid. One thing that has caused some controversy is, do we treat CNS tuberculosis or TB meningitis for longer than routine pulmonary tuberculosis? And most places will, especially in sub-Saharan Africa, will treat for at least a year, many of them for at least 18 months before discontinuation of treatment. Now, regarding HIV, TB, co-infection, recommendation is that HIV treatment should be started regardless of the CD4 T cell count. And TB treatment should be initiated first, followed by your combination antiretroviral therapy or HAART as soon as possible within the first 8 weeks of treatment. However, if you have patients with severe immunosuppression, when their CD4 counts are less than or equal to 50 cells per millimeter cube, you must start the antituberculous treatment and then start ART within the first 2 weeks of initiating TB treatment. All these guidelines are just to lessen or reduce the incidence of IRIS in this, that's the immune reconstitution syndrome in these patients. Now, for patients with tuberculous meningitis, corticosteroids are not, the recommendation for corticosteroids is the opposite of what obtains in a patient with cryptococcal meningitis. So the recommendation is actually for adjuvant corticosteroid therapy, either with dexamethasone or with prednisolone, tapered over 6 to 8 weeks for all patients with tuberculous meningitis. And this has been found to reduce mortality in the short term, reduce morbidity in the short term. Now, the problem now arises in low and middle income countries where you have a patient who has presented with a CNS presentation and you're not sure, am I dealing with a cryptococcal meningitis or am I dealing with a tuberculous meningitis? What do I do? Until you are sure you are not dealing with cryptococcal meningitis, the advice will be to delay the corticosteroid therapy, because if it is cryptococcal meningitis, you are going to worsen the outcome in that patient. So I'll be concluding using this slide. How do you approach an HIV patient or a person living with HIV who presents with a CNS infection or a CNS manifestation. Now you will see that I have put the HIV in bracket. Despite the endemic nature or the high prevalence rate of HIV/AIDS in low and middle income countries in sub-Saharan Africa, many times people are unaware of their status. And Dr. Felichawe alluded to this in her presentation. If people are not ill, they are not tested, and testing rates are still low compared to the endemic nature within the society. So you have to assume nothing. You have a patient who is presenting with a new CNS infection. If the status is not known, please test. If the status is known, what has been the treatment retention status? So has the person been compliant with follow-up? Has the person been taking adherent with medications? What is the immune status? I'm very sure many of you will agree with me that most of our patients do not know their immune status. Yes, they are taking the combination antiretroviral therapy, they are going for their regular follow-ups, but when you ask them, what was your last CD4 count? Or what was your last viral load? Many of them are staring at you blankly, and that is something you may not have access to at the point you are admitting the patient. If the person is a known HIV person on treatment, please do not assume that automatically the CNS presentation is confirmatory of an opportunistic infection. You must remember that they could also have CNS infections that are seen in the HIV negative population. So nothing stops an HIV positive patient from having your run-of-the-mill viral meningitis, your run-of-the-mill acute bacterial meningitis. And then just to give you some direction, you need to decide what is the CNS syndrome. If it's a meningitis, is it an acute presentation or a chronic presentation? That narrows your differentials and allows you to plan your testing and management. Is it non-focal signs and symptoms, or is the person presenting with focal signs and symptoms? The differentials in those two cases are different. These are my references. Thank you once again for your attention, and thank you to the organizers for inviting me for this webinar.
Dr. Ojo, that was a brilliant presentation. Thank you so much. Now, before we welcome 2 questions, I'd like some comments from our panelists. Dr. Laura Benjamin, do you have any comments on the 2 presentations? Dr. Laura Benjamin? Do we have Dr. Diana Saylor?
Yes, I'm here. Thank you, Dr. Okenjo. First of all, Dr. Charwe-Fele and Dr. Ojo, those were fantastic presentations. I think full of really good content, but also really highlighting the challenges of diagnosing and managing these patients in resource-limited settings. I liked that you highlighted the need for HIV testing as well. I like to think of that as sort of the 5th vital sign in our settings because it really changes your differential completely. And, you know, I think just the highlighting of how important it is to clinically think about your patient and then use your history and your exam to generate a really targeted differential diagnosis, test for what you can test for, and then begin empiric treatment many times. And then always having in the back of your mind what you're going to monitor to make sure that your empiric treatment is working and what you're going to use to try a different form of treatment if you don't think it's working. And so I just thought it was a really fantastic presentation. I learned a lot as well, and thank you both very much.
Thank you.
Thank you, Dr. Saylor. So can we go to our questions now? There's a question from Nanke Finway. She's asking, what is the duration of anti-TB if tuberculoma is still present, even after 18 months of anti-TB?
For tuberculomas, you do have to realize that sometimes the radiology may lag behind the clinical features of the patient. So for tuberculomas, if your patient is clinically better, the tuberculoma size is reducing. After 18 months, I think I will discontinue therapy and just follow up with serial imaging. I don't know if Dr. Chawe or any other person has another opinion.
No, I would have to agree with you here. Absolutely. If clinically I have no concerns, inflammatory markers are negative, basic workup is benign, rather than treating the scan, like we are sometimes tempted to, I would either treat the person if they are clinically still unwell, but if they are significantly improved, I would not extend it beyond, because unfortunately what we do when we extend treatment, sometimes necessarily, sometimes unnecessarily, is we increase the likelihood of the toxic complications of the therapy itself. So if there is no clinical need, I would halt beyond the clinical guidelines of the duration of treatment. Treating for longer does not appear to confer any further benefit.
Thank you, Doctor. Dr. Diana Saylor, do you have anything to say on that?
No, I agree. I mean, we know that tuberculomas can last for years, even on imaging. So I think as long as the patient is improving, I would also stop as well.
Okay, we have another question from Vikram Kaur. He's asking, thank you for the excellent talk. May I ask what were your recommendations on starting steroids in TB meningitis? Like how early?
So for TB meningitis, you are supposed to start adjuvant steroids with starting treatment. So if you have a straightforward patient, you know it is tuberculous meningitis, and I'm choosing my words carefully here, you will start adjuvant steroids with your anti-tuberculous therapy. However, think of your prototypical patient. Think of the patients you see from day to day. Yes, there are patients in whom you know that, oh, my suspicion here is cryptococcal meningitis, or my suspicion here is TB meningitis. However, remember, if you think back to one of the first few things I said, some of these opportunistic infections coexist. So the simplest thing you can do, in my mind, is measure the intracranial pressure. If the intracranial pressure is not raised, then you can assume that you are not dealing with cryptococcal meningitis. Start treatment for tuberculous meningitis with adjuvant dexamethasone or prednisolone. But as you are starting it, you are going to taper off over the next 6 weeks. So for tuberculous meningitis, again, if you are sure you are dealing with tuberculous meningitis, you start with adjuvant corticosteroids along with the anti-tuberculosis medications. I hope that answers your question.
Thank you, Dr. Ojo.
Yeah, Dr. Kigucha, you can also ask comments from, we have Professor Griswold, Dr.
Sure.
Patrak, and David Garcia, Hadi Manji. So you can ask comments from them if they have any.
Yeah. Can we have any comments?
Yeah, may I make a comment?
Yeah,
regarding steroids. There's a recent Cochrane database by Dr. Kameshwar Prasad, Mamta Singh, and Ryan. And they were very definite in their recommendations in tubercle meningitis without HIV infection. And they said you should give it for 6 to 8 weeks as per the recommended doses. However, they were not very certain whether steroids help or do not help. in HIV co-infections. So I think it's a little different situation when you have HIV co-infections. Now, I kept quiet during the tuberculoma debate, basically. But what would Tina do if the patient was still remaining slightly symptomatic with her tuberculoma, which is shown on the MRI and which shows a certain amount of perilesional edema at the end of 18 months of therapy?
Thank you, Dr. Katrak. I'm sure a lot of us would struggle with that question, what to do. I think we had a similar debate to this a few sessions ago. I think this was when we were talking about the amoebic abscess that we spoke about, I think, last session. The perilesional edema by itself also is not indication, but if the patient is symptomatic, is the patient symptomatic of the localization of the tuberculoma, or do they have systemic symptoms of the TB itself as a systemic illness? I would debate it strongly and probably not continue longer than per the guidelines. But again, it's purely on a case-by-case basis. If the person is systemically still ill, I probably would consider continuing the treatment, but even that with huge debate.
Continue to have headaches.
I would consider it, but if I did it for a little bit and it wasn't getting any better, I would stop.
Dr. Manish Modi of Chandigarh, he has a series of nearly 90 patients whom he has treated with thalidomide.
Mm-hmm.
And I think from India, I think he has the largest experience of treating tuberculomas with thalidomide with very good results. And he has published all that data. This is just for information that you have to be very selective in your cases where you have tuberculomas which have persisted for 18 months or longer.
Even when the person is clinically well? Is that
talking about symptomatic? I'm not talking about clinically well.
okay?
When there is a radiological and clinical dissociation, I would also stop the anti-tuberculous therapy. We are talking about when the patient continues to remain symptomatic.
Okay, got you.
Thank you. Do you have any comments, Professor Griswold?
Yes, just two short questions. Thank you for these excellent talks. I just want to ask two questions. One is toxoplasmosis, and do you sometimes have the differential diagnosis to lymphoma? Because this was one of the questions in neuropathology at the time. And the second question that's also related to lymphoma, do you have any CMV infections where have this paraventricular lining? Thank you.
Okay, thank you for your question, Prof. Yeah, so for any patient that presents with cerebral toxoplasmosis, especially when you have a solitary lesion, remember that during the presentation, I mentioned multiple ring-enhancing lesions, but when you have a solitary lesion, one of your differentials should be primary CNS lymphoma. And actually, per the recommendations, once you start treatment for cerebral toxoplasmosis, the patient will usually improve within a week, 2 weeks at the maximum. Your patient has started improving. By the time the patient has been on treatment, 6 weeks, in fact, you don't go up to 6 weeks, 4 weeks without improvement, you are likely dealing with the differential diagnosis of primary CNS lymphoma. As to the second question, you said
CMV. CMV.
Ventriculitis.
Yes.
Yeah, it is a possibility. However, in our own, at least my own setting, we are still a bit behind when it comes to making a diagnosis of some of the viral, either opportunistic infections or co-infections that could occur with HIV. But sometimes I also think this is because we are not requesting for them. So as long as we have also an index of suspicion and we can make a request for that to be checked out. But currently, I've not had a case of a CMV ventriculitis. No.
It's very interesting because if I just may comment, in the peak of the HIV, before the antiviral drugs, we did a lot of neuropathology, and CMV was more or less equal with toxoplasmosis in the distribution at the time. So it's interesting that it's not in your country. This is maybe a distribution or I don't know what. Very interesting. Thank you.
It's more likely a diagnostic issue. We are not looking for it, so we are not finding it.
Totally agree
Thank
with
you.
you, Dr. Ojo. It is very true. And even sometimes when you think of it, it's hard to confirm because we do have to state here in sub-Saharan African countries, our person living with HIV is usually not able to afford the serological tests that would confirm anything. And our neurosurgeons are very, 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 very loathsome. They never want to do any kinds of biopsies or anything like that, even when we're considering the difference between toxoplasmosis and lymphomas and other mass lesions. As soon as they hear that the patient has HIV, they say treat for toxoplasmosis. We're not going to discuss it. So I think just as Dr. Ojo says, the matter is not that we don't have it and it's differently distributed in the world, which is still a possibility. But I think a lot has to do with the fact that we do not have the diagnostic capability to identify these things.
Yeah, Dr.
Thank you.
Kipota, I think
Yes. Yeah.
we can move on to the cases and continue the discussion further.
Yeah. Thank you, Dr. Nashram.
So you can introduce all the three case presenters and they can present the case one by one and we continue the discussion later.
Okay.
Yeah.
So we are going to have now 3 case presentations. The first one is by Isabella Asamoah. She's a physician at Kolebu Teaching Hospital, Accra, Ghana. She's currently a resident in infectious diseases. She's a member of the following associations: Ghana College of Physicians and Surgeons, the West Africa College of Surgeons, International AIDS Society, and the International Society for Human and Animal Mycology. She did a dissertation in post-tuberculous treatment outcomes in persons living with HIV. And our second presenter will be Nfuama Kwatu. She's a pediatric neurologist at the University Teaching Hospitals in Lusaka, Zambia. And she will present a case of complicated meningitis. And our last speaker will be Lauren Chishimba. She's a neurologist from Zambia. Welcome, Isabel. Isabel, the floor is yours.
Thank you very much.
Yeah, Bela, go to the slide.
Hello. Thank you very much, and thanks for the opportunity. I'm very thankful to Dr. Ojo for giving an excellent review on chronic meningitis in resource limited. So I present a case of a woman who had chronic persistent headache and chronic cough, and who is also an ART experienced person living with HIV in Ghana. So I present a 44-year-old woman. She's a known person living with HIV and on ART And she has been on ART since 2011 till her current presentation. She had good adherence till about a couple of months ago. During the past year, when the adherence became very poor, she admitted to that herself, and she attributed it usually to being forgetful and also challenges she had with raising a 5-year-old child who had a seizure disorder. Looking through her clinical notes as well, she had issues with clinical appointments, and also the pharmacy had noted that she was missing her pharmacy appointments as well. Her last viral load was done somewhere in December 2019 and showed viral copies of about 103,000 per mil. Reinforcement counseling was done for her. This patient had presented a few weeks earlier to one of the local hospitals in Ghana with a 2-month history of severe recurrent headaches and a 3-week history of cough. Presumptively, she had had artemisinin combination therapy for malaria, had been given some analgesics for her headaches, and also presumptive treatment for pneumonia. She also was given a mucolytic, that's carbocysteine containing cough mixture, but that didn't provide her any relief. That local hospital, she was investigated, and among the investigations that were done was that of an MRI. So upon receipt of the MRI at the local hospital, she was given a referral to us on account of the small chronic infarct that had been found in the anterior left internal capsule of the MRI. So when we first saw her at the clinic, we recently saw her at the clinic, she described a kind of headache that was gradual in onset, usually will wax and wane with pain intensity, which usually should describe as very intense or utterly horrible. By the 2nd of September, that's when we saw her before admitting her, she was having the headache being persistent and now said it was very horrible. She had had no clinical response to any of the over-the-counter analgesics. She, however, denied fever, chills, neck pain, vomiting, blurry vision, history of seizures, photophobia, or head trauma. The cough she's been having was productive of yellowish sputum. There was never any history of hemoptysis. She had no pleuritic chest pain or dyspnea. No past history of PTB treatment. She had lost weight, but denied dysphagia, odynophagia, or any diarrhea recently. She, however, noticed that she had had this pruritic papular rash, which had affected her whole body, particularly her face and trunk. When we examined her, she was a woman of short stature with a BMI of 21 kilogram per meter square. And as I said, she admits that she had lost about 13 kilograms during the past year. She had a pale conjunctiva, had oral thrush, but no palpable peripheral lymph nodes. She was afebrile and all other vital signs were normal. She also had multiple rash of multiple morphologies, which clinically we thought were suggestive of flat warts, seborrheic dermatitis, and pruritic papular dermatitis. She was very conscious and alert, had no signs of meningism, no cranial nerve abnormalities were noted, and the rest of the examination was unremarkable. So then we made a diagnosis of treatment failure with possible esophageal candidiasis, a possible cryptococcal meningitis with cryptococcal pneumonia, We're also thinking of a possible PTB to rule out TBM. And of course, the dermatological manifestations she had. We requested for the following labs: full blood count, serum crack, that's serum cryptococcal antigen, liver function test, viral load, a repeat of that, because the last one was about a year ago, chest x-ray, and then sputum gene expect. And she was given empirical treatment for cryptococcal meningitis, started on fluconazole 800 milligram daily, pending review upon the serum crack results, and thereafter. Also put on prophylaxis for cerebral toxo, and the analgesics then was changed from the NSAID she was taking to opioids, but then with stool stiffness. And then she was asked to come in a week with the results. Since she refused admission, she said she had no one to take care of her child at home. So we didn't see her in the following week that we scheduled her for. Her headaches had improved. Meanwhile, she had visited another local clinic with a cough as well, which she described as very worrying, and had been prescribed another antibiotic and given mucolytics again. She had been called by the lab that her serum crack result was ready. So she went for it and brought it, which was positive. She, however, had not done her BUE then, and then the other labs that had been requested. So we requested a BUE again, and then this time we requested an LP for minimally cell count, cryptococcal antigen titer, bacterial antigen PCR, and then gene experts. And the fluconazole was started, this time at a high dose of 1,200 milligram daily, to report to us if she had any GI symptoms, and was also given an antitussive to help suppress the cough, but she never bought it. She was recounseled again and asked to adhere to her clinical appointments, and also offered admission, which she declined again. So this is a summary of the laboratory test we had from her from the first day of diagnosis up until the time she finally accepted admission and then discharge. So the first week, she did a full blood count that showed a white cell, total white cell of 4.6 with lymphocytes of 1.73, and sodium was normal, potassium normal, GFR was more than 89. Then after the second week, when she defaulted and came back, she finally came with, after the serum crack, we realized the serum crack was positive. She came back having bad headaches. So after 3 weeks, she accepted to do the LP. So she did the lumbar puncture. We did the lumbar puncture for her. And then we asked for the CSF cryptococcal antigen titer. We asked for CSF microscopy and the bacterial antigens as well. So the results came with a titer, CSF crack titer of 1:2,560, about one of the highest we've seen so far, with polymorphs 0, lymphocytes, like so more of a mononuclear pleocytosis of 10, RBCs of 3, and all the other bacterial antigen screen were negative. She also came then with a gene expect of the sputum, which did not detect MTB complex. She again refused admission because she said she had no money and had no one to take care of her in the hospital. Neither did she have anyone to take care of her sick daughter at home. So she again went home, but by the 5th week, her sister brought her in, having very bad headaches. She could barely open her eyes. She could barely talk. Then she had agreed, we did a therapeutic lumbar puncture for her. Unfortunately, we couldn't use a manometer because of lack of funds then. But then we put in, when we put in the needle, it just gushed out. Usually we are able to count the number of drops. About 40 drops per minute tells us that the pressure is quite high. And we, about 20 drops is equivalent to 1 mil. So we are able to remove about 8 mils to 12 mils when they come. Most of them have financial issues. So adding on the cost of a manometer defeats our purpose of convincing them to get the other drugs and then the other further evaluation whilst they are on admission. So after 5 weeks of diagnosis, after 4 weeks of diagnosis, we're finally able to convince her to stay for a possible amphotericin therapy. So on day 0 of the start of the amphotericin B deoxycholate therapy, we had a baseline again, full blood count, that showed WBC of 5.05, lymphocytes of 1.52, platelets of 215, and a GFR, which was more than 89. So we started with the amphotericin infusion. We gave it most of the time over about 4 to 6 hours. And then by day 2, we had a repeat of the BUE, and we had a fairly normal BUE. So we continued, gave 4 doses. After the 4th dose of amphotericin, within the first week, we saw some derangement in her BUE. The sodium was still in the normal range, 138, but then the creatinine had increased to about 172 and the GFR of 31. During our clinical reviews, we realized that she was not taking much orally, and aside our pre-hydration, when we put her on the post-hydration, sometimes we go and get back to the ward, it's not done. Then we had another lab after day 4. We had another from another facility, which also showed some renal derangement, but that puts the GFR of about 44. So we decided to omit the amphotericin dose. And then also from that lab, it contrasted with our previous lab. The potassium was 2.6. And since we know that usually amphotericin will cause a hypokalemia, we tended to agree more with this lab. So we omitted the amphotericin dose, rehydrated, and started potassium replacements with deficits. Then we restarted again in the fifth week and gave a total of about 8 doses within the 6th week, from the 5th week to the 6th week. But by the end of the 6th week, our GFR has dropped to about 36, and her HB had also dropped to, the HB had dropped to about, it was about 8.8. So we had to stop the amphotericin, and then at that time too, she had run low on the amphotericin as well, and she also had refused persistently blood transfusions.
Dr. Isabella, can you please summarize? You're running out of time.
Okay, so during her admission, she had 9 doses of amphotericin B deoxycholate, with a dose ranging between 0.7 to 1 milligram per kg per day. Also had fluconazole of about 800 milligram with the dose adjusted because of her GFR. We did pre and post rehydration. We did potassium repletion. Also gave MAC sulfates when the potassium was less than 3.5 and magnesium itself was less than 0.7. Also gave magnesium trisilicates, but we had to stop somewhere along the line when she had diarrhea. We did 3 therapeutic LPs. At a point in time, she became very confused, and then she started having headaches, but she refused LPs again, and then she started having seizures. So when she started having seizures, we sought permission from her sister, after which we did the LP for her. Then we started IV levetiracetam. At the point where she was confused, we were torn between, could it be just the ICP or another opportunistic infection? So we gave a pyrimethamine-based clindamycin toxoplasma treatment. Again, as I said, she refused blood transfusion. So in summary, I presented a 44-year-old ART experienced woman who had failed first line treatment regimen with cryptococcal meningitis and possible cryptococcal pneumonia, complicated by renal impairment, that's electrolyte imbalance, with a possible increase in intracranial pressure manifested as seizures and neuropsychiatric manifestation and anemia. Also with a presumptive diagnosis of cerebral toxoplasmosis. Post-discharge review, we saw her a week after she had not done her lab again, but 2 weeks after she came with a BUE, the potassium was normal, the creatinine had gone down, the GFR was 94.2, but her HB was still low, and she had a pancytopenia for which we thought it might be the pyrimethamine toxicity. So we thought stop the pyrimethamine-based therapy. We continued on Septrin 960 daily. And then we switched to second line after 2 weeks of stopping the amphotericin B deoxycholate. Currently, she's on fluconazole 800 daily. We wish to complete an 8-week course, then continue with 200 milligram daily as maintenance course. We wish to monitor her viral load and possibly the CD4 count. That is not for free, so she would have to pay for that. And she's currently on levetiracetam 250 milligram.
Thank you, Dr. Isabella. Thank you so much. So we are really running out of time. Can we have the next presenter, Dr. Fawa Kawatu? Dr. Isabella, that was an excellent presentation.
Thank you.
Hello, can you hear me?
Yes.
Okay, I will share my screen shortly.
Bella, you stop sharing.
Isabella, could you stop screen sharing, please?
Maybe we can go to Dr. Lauren Chishimba. Is she ready?
I'm trying to put my presentation.
Click on the share screen button.
Welcome, Dr. Kawatu.
Okay, thank you. Good afternoon again, and good morning to everyone else. I'll talk about a child that we had on our pediatrics ward. He's a 7-year-old boy who had no past medical history and presented to us on day 5 of an illness. He had fevers for 2 weeks, as well as headache, diarrhea, vomiting, and right-sided hemiplegia. So according to mom, he was well until 5 days prior when he complained of a headache and fever. 3 days after this, he had developed vomiting and diarrhea, which was then followed by the fact that he stopped talking, and mom noticed that he was weak on the right arm and leg. On the day of admission, when he presented to us, he developed generalized tonic-clonic seizures, per description, that were resolved at our local clinic before coming to the main hospital with benzodiazepam. In his past medical history, his review of systems revealed that he's had headache, which was not characterized. He was aphasic. He had non-projectile vomiting and fever for the last 2 weeks on and off with diarrhea. There was no history of weight loss or night sweats. His past medical history was uneventful. Is that he was a product of an uneventful pregnancy. He was a term delivery with no developmental delays. I must add here, I know this is an HIV-based webinar, but he was HIV negative. His family medical history was unremarkable, with no neurological or neurodevelopmental history. His physical examination at the time of admission was that he was a well-nourished 7-year-old boy who was febrile to touch and temperature recorded at 39 degrees with tachycardia and tachypnea. His BP at the time of admission was not recorded. His neuro exam was significant for decreased level of consciousness. GCS was pegged at 10, mostly due to the fact that he was aphasic. He had global aphasia. His neck was supple. He had no kennings of Brudzinski signs. On his cranial nerve exams, his pupils were equally reacting to light. He had a conjugate gaze deviation to the right and a right upper motor neuron facial weakness. His motor exam showed normal muscle bulk, hypotonic right hemiparesis with a power 1 out of 5 in the right upper limb and lower limb. He was areflexic on the right and normal findings, motor findings on the left. Other systems examined were normal. So within the first 2 days that he was admitted, we managed to do labs and got some results. His random blood sugar at admission was 4.6. The rapid tests for malaria and HIV were negative. We did a CSF. Unfortunately, the pressures were not measured at the time in the ED, and these results came to us about close to 48 hours later, and they showed no cells, negative gram stain, negative Indian ink, and a protein which was elevated of 0.74 and a glucose of 2.85. This was within the normal lab ranges for the glucose, but looking at our patient, it was difficult to say whether this was low or not. His full blood count was mostly that of a neutrophilic picture, and his HB was 11.4 with a raised platelet of 5.28. We were unable to perform ESR at the time due to our lab. So an impression of meningoencephalitis was made, which we thought was complicated by a stroke, and also the possibilities of a space-occupying lesion like an abscess or a malignancy, or indeed a tuberculoma. So our plan was to immediately admit the patient to the PICU, and he was empirically started on acyclovir, dexamethasone, ceftriaxone, and metronidazole. We did a chest X-ray, which showed some perihilar lymphadenopathy and not much to talk about. I must mention here that this patient had a very long hospital stay. And his course of illness was that on day 2 only is when we managed to do a CT and it was reported as normal. On day 4, he was transferred out of the PICU because he was occupying a bed space that had the vent and we needed a vent space. So he was put on the pediatric general ward. His examination kind of remained static till about day 13 when his Glasgow Coma scale was now 11. And mostly he lost points because of his lack of speech. But now he was said to be moving all 4 limbs and his physical exam was otherwise unchanged. Between days 14 and 17, he developed status epilepticus, which was aborted with phenobarbital, and subsequently developed focal onset seizures, which were involving the right face, arm, and leg. His Glasgow Coma scale was 10, but then between these days, he developed right eye ptosis, a fixed and dilated right pupil. Because of these findings, he was transferred back to the PICU and started on dexamethasone. Mannitol would have been the best drug of choice at this point because we were afraid of an ankle herniation, but it was not available at our hospital. And this is only when that the neurology team was consulted. Between days 18 and 20, his full blood count was repeated, and again it showed neutrophilia, and it was noted on his electrolytes that he was hyponatremic. A repeat CT was done after the fact that he had a suspicion of raised intracranial pressure, and it was reported as having diffuse leptomeningeal and basilar enhancement. There was dilated lateral third and fourth ventricles with loss of gray-white differentiation. And basically this was his CT at the time. So his CT and a repeat CSF showed the above findings, I mean the findings I mentioned earlier, but also his CSF was negative for gene express. Now, based on the compatible clinical history, the CSF findings and CT findings, an empiric diagnosis of TB meningitis was made, and the patient was initiated on anti-TB treatment and continued on the dexamethasone. On day 25 only is when we could get the neurosurgeons to place a shunt, and his full blood count continued to have neutrophilia and hyponatremia. At this point, after they put the VP shunt, he developed a new onset fever after being hyperexic for 25 days. So another CSF was done, and it revealed 64 cells of white blood cells, which were not typed, but there was no growth on culture, and the gene express again was negative. Unfortunately, on day 37, his Glasgow Coma scale dropped to 3. This was because he developed new respiratory distress, which was presumed to be a hospital-acquired pneumonia. I must make mention here that this patient was admitted right around the time after, it was about a month after the first COVID cases were reported in Zambia, but a COVID test was not done on this particular child. He stayed in the hospital for a very long time, and he had a lot of ups and downs. But on day 71, his GCS remained at 6 for a long time. His condition remained static, and he was also noted that he had dilated bilateral pupils. He was drooling with no clinical seizures at the time, but then he also remained on phenobarbital. On day 80, we were called in again by the ID team to do a neuro exam for evaluation of brainstem function. He was groaning and grimacing to noxious stimuli at the time. His Glasgow Coma scale was 6. His cranial nerves showed dilated bilateral pupils with no light response. There was papilloedema and a complete right third nerve palsy. The left eye was, the pupil was dilated and unresponsive to light with intact extraocular movement. The corneal reflex was present. He had no facial asymmetry, and he had a present gag reflex, and he was drooling, but he could protrude his tongue whenever you tried to open his mouth. His motor exam revealed atrophy of all muscle groups. This can be explained by disuse. He was bedridden for quite a long time. He had increased tone of all the 4 limbs and increased deep tendon reflexes, but no clonus. His left limbs had grade 3 power, and the right limbs had no power at all. By day 110, his mom decided to leave the hospital. But between that time she left the hospital to day 132, when he finally died, he was admitted twice for aspiration pneumonitis. So I'll talk a bit about tuberculous meningitis, though Dr. Ojo did a very brilliant job at it. It's the most feared extrapulmonary complication of TB, and it carries about 100% mortality in untreated cases. According to the WHO, the annual incidence of TB is about 8.7 million worldwide. And the majority of cases happen in our countries, in the low-income countries. Approximately 10% of patients with TB will develop a CNS infection, CNS manifestation of the disease, with children being more commonly affected. Clinically, approximately 20% of patients having TBM present with stroke, whereas infarction can be found in up to 50% of patients when more sensitive neuroimaging techniques are used, for example, MRI. Infarction most commonly affects the basal ganglia, but it may also involve the cerebral cortex, the brainstem, and the cerebellum. This is due to the fact that most patients with TBM will develop vasculitis. So there was a study done and published in the American Heart Society, which talked about the frequency and impact of cerebral infarctions in patients with TB meningitis. Here, I'll talk mostly about their radiological findings, which were that most infarcts happened in the basal ganglia and thalamus at 20%, like I talked about earlier on, and some of them would happen in the brainstem at 19%. Other findings of note were tuberculomas, which were 57%. Now, interestingly enough, in India...
Dr. Kawatu, thank you so
Yes.
much for the presentation, because we're running out of time and we have another case. Can we have
Okay.
Dr. Lauren Chisimba to present now?
Okay, thank
Thank
you.
you. That was an excellent presentation. Dr. Lauren, the floor is all yours. Is Dr. Lauren around?
Yes, I'm around. I'm just trying to share the screen.
Can you summarize your case briefly?
Oh, okay.
Yes.
Okay.
You can click on the share screen button.
Yeah, I think I'm just having a bit of some technical challenges finding my screen. Sorry about this. I'm using a different gadget that I'm not very used to. Sorry again. Maybe I could just quickly.
Yeah, you can present, directly without, there is problem.
Without the PowerPoint. Yeah. Okay, all right. Okay, so very quickly.
I'll share it for you from.
All right,
okay.
That would be great. Okay, thank you. All right. So very quickly, I'm presenting a 47-year-old right-handed male who presented with cognitive decline over a period of 2 months, which were characterized by tangential speech. He was wandering aimlessly. He had memory impairment and was getting lost within the house and would ask the same questions over and over again. This was in December of 2019. He was a known HIV patient who'd been started on ART since 2004. And from 2009, he'd been on an regimen that consisted of tenofovir, ampicillin, and atazanavir boosted by ritonavir. At that time, he was found to have virologic failure. 3 months prior to this presentation in December, he'd also been commenced on TB treatment based on CSF studies. And at that time, he had presented with new onset seizures. He had confusion and headache. with constitutional symptoms, and his CSF showed a low glucose and a high protein, but the cryptococcal antigen was negative, and RPR on serum was also negative. He'd also had brain imaging with an MRI, and at that time, it was noted on his MRI that he had these diffuse white matter changes on T2 flare. I'm going to share that. His CD4 at that time was 54, and viral load was 522. So essentially, he was doing okay virologically. Next. And these are the images that were seen. This is 3 months prior to his cognitive decline that I'm going to talk about. You can see the white matter changes at different levels of the brain. Next. In his review of systems, whilst presenting with the cognitive decline, he'd also presented with the fever, dysuria with intermittent headaches. Let me mention as well that he'd also been, at the same time, was being followed up for urethral stricture, which later in the course of the months, he had urethroplasty. His past medical history was significant for pulmonary TB diagnosed in 2013, 2014, and he completed treatment at that time. He didn't have any other history, for instance, hypertension or diabetes. He was on carbamazepine by the time he was presenting with the cognitive decline based on the TB that he was being managed for, and he was on CART, as I mentioned above. He was of sober habits up from 2004. Next. So on exam, on this presentation when he had cognitive decline, he was oriented to person only and place. He had very poor memory in all domains. He was naming poorly, he would not comprehend, and he was failing to perform complex tasks. He had psychomotor slowing, but his cranial nerves were intact. Of note on the motor exam was that he had some hyperreflexia in his bilateral lower extremities with crossed adductors, but his planters were down. His power was normal, his bulk was normal, except for lipoatrophy, mostly on his face, because from previous years, he'd been on Triamine as well. He had a positive glabellar reflex, but no palmamental or snout reflex. His coordination was intact, and he had no meningism. Next. We had done imaging at that time in December, and if you see what was on the imaging, again, it was MRI. Basically, it appeared rather the same way that it did 3 months prior when he was diagnosed with the tuberculosis. Next. So at this point, we were thinking that he could be having a diffuse cerebral damage, brain injury, which is involving the frontal lobes, given the frontal release signs, some pyramidal tract involvement as well. So given the cognitive decline within a very few months, it was thought that could this be HIV-associated neurocognitive dementia? Were we dealing with a metabolic encephalopathy? Could he have had PML iris? Given those white matter changes, we had thought, even though the PCR for PML 3 months ago was negative, but the sensitivity can be from 74% to 95%. So we also thought maybe we're dealing with the PML iris. We also entertained an encephalitis, an infectious one versus an autoimmune one, and maybe a paraneoplastic process. However, the very next big differential was a UTI with delirium, given that he had these constitutional symptoms and this urethral problem that he had with the fevers. Next. His flu blood count at the time, he had a very slight leukocytosis. We didn't have an electrolyte panel. We were not able to do the test, and so we didn't know. But his urinalysis revealed numerous past cells. CD4 at that time were still, we only had the one that he had done 3 months before. So with this, we thought that he was being, he had a UTI and possibly he had a delirium. He was treated with antibiotics and his urinary symptoms resolved. I must mention that during this time, we had just had the wave of COVID beginning. And so follow-up was a little bit difficult with the patient. And also he didn't live with his wife who would come in and out to help him out. The wife had to come from another province where she was working. So she couldn't consistently come and do quicker reviews. However, 6 weeks later from the presentation, he came back. They reported that the urinary symptoms had resolved. However, he continued to have cognitive dysfunction. And so we presumptively gave him some prednisone with a view to manage a possible PML iris. And the wife, after they left, reported that after we gave him the prednisone, he had quite remarkably improved. He was managing affairs by himself. Next, please. Then in June, which would be sometimes 6 months or 5 months to 6 months from the onset of the cognitive decline, the wife managed to bring him back in and said that the cognitive decline had improved when it gave him that 4 weeks of steroids, but then had recurred and was worsening. He had no constitutional symptoms. At this point, he was getting his family members, and he was on exam. He was also perseverating. And so again, we thought, could we be dealing with a hand situation and also a CNS OI? His bloods, as I'm going to show you, were essentially normal. And so we were concerned about CSF CSF HIV infection. As you see on the screen, his white cell counts were normal on full blood count, and the rest of the panel was normal, and the metabolic panel was also normal. His HIV at that time was 212, the viral load, a little bit high, but still under what we call a suppressed value. In our country, we're using the cutoff of 1,000 copies per mil. His CD4 has dropped, as you can see, from 288, but his CSF was Gram-stain negative. It was a bit traumatic, so the RBCs were 1,200, leukocytosis of 7. His CRAG was negative. His glucose was 2.4, but his HIV viral load in the CSF was markedly elevated, almost 90 times more than what was found in the serum. Next. And so he was then, he had a panel for resistance for his HIV in the CSF. And going by the different mutations that was found, mutations for resistance, he was then put on this dolutegravir, lamivudine, and darunavir. He had showed multiple resistances and with common mutations, one of them also from lamivudine. As at now, as I speak, he's currently, after he was started on this regimen, he's currently functioning very independently. His wife, his family feel completely that he's back to his normal baseline. He's able to go about his usual business. His seizures have been over for over a year. His exam was essentially normal, and on MOCA, he was actually able to score a 28, even though we can't compare to what he did previously, but this was pretty good. His repeat normal CSF, which was done about last month, is normal with no HIV detected in it. Next. So given the significant elevation of the CSF viral load in comparison with the plasma, we made a diagnosis of symptomatic CSF HIV escape / discordant syndrome. Next, which is defined by Peluso and Canestri et al. In their papers. They define CSF discordance as a CSF viral load that's greater than 0.5 or log 110 in the plasma, and an escape whereby the CSF viral load is above the limit of detection in the serum. Next. And the pathogenesis for CSF escape and discordance, really, we're talking about there being HIV RNA in the CSF as is supposed to be a proxy for independent replication of HIV in the brain parenchyma itself. And when they've done studies, they've found that HIV will isolate itself in these sort of reservoir areas of the brain, and it will be found in the neurons, the astrocytes, and oligodendrocytes as well. It's thought that it is passively moved from the plasma by immune cells into the central nervous system where it begins to replicate. You can also have activation of a latent reservoir from pre-outbreak, for instance, from the very first time when someone is infected, you get some HIV being latent in the central nervous system, and then they begin to multiply from there. Next. The prevalence, so we know that CSF, HIV is able to access the CSF right at any stage of HIV. And before the the pre-ART era, there was HIV-associated encephalitis, mainly because of CSF HIV infection. But after the advent of the HIV, they've seen a decline in the CSF HIV because of reduction in the peripheral HIV. And so there's been a little bit of a shift, although we are still able to see some people who are still suppressed, but they still show CSF HIV infection. I must mention at this point that true prevalence is not very certain, because again, looking at those definitions that I mentioned before, if you're looking at, for instance, escape, where we're saying it depends on the limits that you set for your assay. So if your assay has got a limit of say 50 copies per mil, or maybe 40 copies per mil, that would determine at what point you might say that there's CSF escape or not. Next. So looking at the prevalence, there's been studies that have looked into the prevalence of CSF escape, and generally all the studies, the prevalence is about 1% to about 10 or 11% based on these studies that I've shown over here. Next. And the clinical presentation for CSF escape, the spectrum is wide and it covers both asymptomatic clinical presentations to coma. The presentation can be acute, subacute, and can involve sensory, motor, and cognitive symptoms as presentations, including headaches, meningoencephalitis, personality changes. Next. The risk factors include a low starting off CD, like if you've had the lowest CD that you've had, if it's been very low in the past, you are at risk of developing CSF escape. A very low viremia, low level viremia in plasma is also associated with, is also a risk factor for CSF escape. Maintenance on the same ART regimen for many years has also been shown to be a risk factor. Ritonavir boosted protease inhibitor.
Please summarize.
All right, thank you. I'm about to end actually. Yeah, and so the workup, of course, you can suspect CSF escape given you can suspect CSF escape if a patient, as the patient that we had, and the workup is as shown above, you expect on MRI to see some hyperintensities on T2 and on flare. And also in CSF, an Indian study showed that there are those who have symptoms who may have an acellular CSF. But if you are symptomatic, they had shown in this Indian paper that the CSF can have high protein, abnormal glucose, and pleocytosis. And the treatment for CSF escape includes optimizing ART. Steroids have received a mixed picture, and you cannot really rely on them, although it was quite interesting that our patient seems to have responded a little bit to steroids. Next. And those were my references. Thank you.
Thank you, Dr. Arore. That was a very nice presentation.
Thank you.
So now I'll give back the chair to Dr. Meshram.
Yeah, any brief comments from any of the panelists on the cases or any part of the session?
Yeah, hello?
Yeah. Lara, yes.
So I think they were all interesting cases that illustrated the topic for the day. I'm not a pediatrician, however, the 7-year-old that was presented, the differential of TB could have come up just a little bit early, and it just shows you the tortoise course sometimes we go through in resource-limited settings or in sub-Saharan Africa in making a diagnosis, because that 7-year-old had meningoencephalitis as the presumptive diagnosis. And I think the clue there was the infarct. I think there was, if I'm correct, there was an infarct on the initial CT that was done. So I think if we see cases like that, that's the point to even do a trial of anti-tuberculosis drugs while you are investigating the patient.
I thought there was no infarct on the CT.
I thought she said there was an infarct. Who
Sorry.
presented the case?
May I?
Yeah.
So the first CT that was done on the day of admission was reported as normal.
Oh,
The
okay.
second CT, yes, the second CT showed hydrocephalus. Though when you look at it closely now in hindsight, there's a bit of infarct in the basal ganglia. But at the time the second CT was done, the neurology team was not consulted. It was the general pediatricians that were managing this patient, and they looked at the CT and they just looked at the hydrocephalus and it ended there. But yeah, there was no infarct then.
Yeah.
I was a little intrigued by the conjugate deviation to the right in your first mention.
Yes.
When you look towards the side of the hemiplegia, I think the infarct is usually in the brainstem. When you have a
Yes. So
hemispheric
just
the eyes deviate to the opposite side. The exception to the rule of that is that did he have any non-convulsive epileptic seizure which positively deviated the eyes towards the right side?
So if I'd finished, you would have seen that he did have an infarction of the basilar artery. The distal part of the basilar artery was infarcted, and indeed, I don't know whether he did have any state of non-convulsive status epilepticus because no EEG was done during the course of his stay in the hospital.
Just raising that possibility, I thought that the infarct could have been in the brainstem because the conjugate deviation of the eyes was towards the side of the hemiplegia.
Yes.
Okay, and subsequently, I think he did develop cranial nerve palsy, suggestive of a right third nerve palsy.
Yes.
Any other comments? I think we had a great and unique session. It was an all-women session for the first time in last 13 sessions. And on the flyer, I was the only odd man out. And I would like to thank Dr. Agustina, Dr. Lara Ozo, Dr. Kigocha for excellent chairing the session. And we had wonderful talks by Lara and Tina. And excellent cases by Isabella, Fama, and Chisimba. And I would like to also thank Professor Raj Shakir, Professor Griswold, Professor Christina Mara, Professor Saroj Katrak, Dr. David, Hadi Banji, and Professor Stu for being with us. And thank you, Diana Saylor, for being with us as an invited panelist. We don't have session on next Saturday, but on 12th, we have a very interesting session and talk by Professor Van de Beek on bacterial meningitis and Professor Brower on brain abscesses, and we'll have two interesting case presentations. So see you on 12th of December. Thank you very much. Thank you all for being with us and excellent contributions by everyone and excellent talks by Augustina and Lara also.
Thank you very much.
Thank you very much.
Righto.
Righto. Thank you, David.
Bye-bye.
Hello.
Thank you, Professor.
Sorry.
Thank you very much for being with us.
Thank you. Nice meeting, and thank you. Sorry, I had to answer a phone call now with some urgent business. I was a little distracted.
Thank you.
Thank you. All the best.
Thank you. Thank you, Lara. Thank you, Bela.
Thank you. Bye-bye.
Yeah, we had a great session. Excellent session.
Thanks.
Thank you, Mansi.